And good morning, good afternoon, good evening, everyone. Welcome to another week of the Global Café. As you may know, my name is Kara Cruz, and I'm a Senior Policy and Project Coordinator here at the IFA. Today, I am very excited to be introducing you all to Dr. Danni Collingridge Moore, who is joining us here from the UK to speak about older persons and end-of-life care. Danni is a research fellow at the International Observatory of End-of-Life Care at Lancaster University, and is the Dowager Countess Eleanor Peel Trust Sir Robert Boyd Fellow, which is a 3-year postdoctoral fellowship and quite a mouthful, awarded to a study titled Living and Dying in Care Homes During the COVID-19 Pandemic, What Worked Well and Why. So some of you who attended the IFA's Global Conference on Aging in Bangkok or the Canadian Conference on Gerontology and Geriatrics in Toronto this past year may have had the pleasure of meeting Danni in person and learning more about this specific body of research. So during the COVID-19 pandemic, Danni was seconded to the Cabinet Office as a subject matter expert on adult social care and was awarded an MBE in the 2022 New Year's Honors List for her work during this time. Prior to this, she supported the England arm of the EU-funded PACE program of research, which compared the effectiveness of palliative care for older people in care homes in Europe, and then subsequently led to the development of the PACE Steps to Success intervention, which is a free-to-use resource for care homes translated into 6 languages. So thank you very much for joining us today, Danni.
Thank you.
Before we get into a conversation specifically on end-of-life care for older persons, I was wondering if you could share with us some reflections on how you became interested in the field of aging in general.
Well, firstly, thank you for having me here. It's a real pleasure, and after attending the conference in Bangkok last year, it's lovely to be back involved. So my background is really in geography and kind of health research. So I'm not a clinician, and I always like to make that disclaimer relatively early on. But my interest in kind of end-of-life care for older adults really began when I was looking at some data on care homes. And in the UK, a lot of care home residents are kind of excluded from some of the larger data sets that we have. And there's a sense that once somebody enters a care home, they're almost a little bit out of sight, out of mind. So from that, my PhD looked at length of stay in care homes, and I was lucky enough to work on a PACE study, which again was, like you say, looking at palliative care in care homes in Europe. So that's really where the interest came about. And then after that, obviously COVID happened, and it had a massive impact on older adults and care homes, particularly in England. So my current research, like I say, is working in COVID-19 and really looking at how care homes experienced it and how we can improve care in the future. So as part of that, I was lucky enough to be in Canada in October as part of a Churchill Fellowship. And that was looking specifically at end-of-life in care homes. And I had the opportunity to visit a few care homes in Canada, which was an amazing experience. So although my research mainly focuses on care homes, I think a lot of the issues we see in care homes for older adults, we also see in general for older adults in different settings.
Perfect. Thank you very much for sharing that. So recognizing that palliative care is a topic that receives a lot of stigma and that we may all be joining today's conversation with different ideas of what end-of-life and palliative care is, could you kind of explain what you understand palliative care to be?
Yeah, so this is an interesting area because when we talk about end of life and when we talk about palliative care, different countries use different terms, and even within countries, it can be sometimes difficult to understand exactly what people are referring to, and there's little kind of consistency. But loosely, palliative care aims to improve the quality of life and alleviate suffering of people with advanced or life-limiting conditions. So I'll read you out the World Health definition of palliative care because I think it's really useful. So it says, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and the treatment of pain and other problems, physical, psychosocial, and spiritual. And the two things I really like about this definition is, firstly, it concentrates on patients and their families. So it's taking quite a holistic approach to care at end of life. but also it doesn't just focus on the physical issues associated with end of life. It brings in the psychosocial and the spiritual too. So normally palliative care, and again, I guess this is coming from a UK perspective, looks at kind of the last years, months, weeks, days, potentially hours of life. And it's often used interchangeably with end of life care. And certainly for this conversation, I think we can use them interchangeably. But the reason the terms are somewhat difficult for older adults is because palliative care is normally used, or it's normally talked about at the diagnosis of, for example, cancer or heart failure. So for older adults who don't have a specific diagnosis and are approaching end of life, we sometimes more talk about end of life rather than palliative care. And certainly, in Japan, palliative care is more commonly used to refer to, say, cancer or patients with cancer rather than older adults. So we'd use maybe end of life to talk about end of life in older adults, or palliative care in older adults. So basically, either one's fine for this conversation.
Okay, thank you for clarifying that. So just to confirm my understanding, end of life care is almost like a more general, overarching term, whereas palliative care can be understood to be more specific, like disease specific.
I think it's more used, in my experience, palliative care is more used for, when we talk about cancer or specific diagnoses. But the principles of palliative care and a holistic approach are applicable to anyone, including older adults. And that's really important to make that point.
Perfect. Thank you very much. So as we discussed, there can be many misconceptions about palliative care and end of life care, as this is a topic that remains hidden for many of us until we have a direct experience with someone we care about or ourselves. So what are some common misconceptions that you come across?
So you're completely right. It isn't an easy topic to talk about. And often, like you say, when we start talking about end of life, or when we start talking about palliative care, it can come at a time when we need, to have that conversation rather than maybe earlier on. So it can be a really emotional topic. I think the two main misconceptions are there's sometimes a bit of a belief that palliative care happens when all curative treatments end. So it's almost, sometimes you hear, a patient's become palliative, and you have that real distinction. And that's not the case with palliative care. The aim with palliative care is to integrate the care with ongoing treatments. So it's not a kind of hard stop in that sense. And it's really dependent on the person and their situation. And I think the second misconception that comes from that, again, is that palliative care is only delivered when other treatment options have been exhausted. And again, that's not the case. It can be delivered ongoing with other treatments. So the approach is ideally integrated. Palliative care neither hastens or delays death, so it really can be delivered alongside curative treatments. But I think the other view sometimes that we have of palliative care is that it's only for patients with cancer and it's only delivered in a hospice. And again, not true. Palliative care is for anyone potentially approaching end of life, including people with more than one diagnosis, or older adults with multiple diagnoses. And palliative care to some extent can be delivered in any setting, be that long-term care facilities, hospitals, or the home. So it's maybe much wider sometimes than we think.
Thank you. And I think there's so many different professions involved in that as well. Like when you were acknowledging that it's not just physical, it's psychosocial, it's spiritual. So I'd love to get into that a little bit further on. But first, part of the ethos of the Global Café series is to learn from leading experts on topics related to aging and to support our audience in being aware of cutting edge research. So what does good palliative care look like today, or best practice, and how can this be enacted?
So I think for me, good palliative care for older adults has a lot of similarities with what we think of as good palliative care in general for younger adults, or for anyone. So for me, good palliative care is started early. So it started early in conversations, and it includes conversations not just with the patient, but also with their family members. I think as well, like we've talked about a little bit, it's integrated with other treatments, be that, for example, medication for dementia, or any of the conditions that the patient might have. And obviously with older adults, you're potentially dealing with, multiple conditions. So it's really important to understand the person and their symptoms and what they need. I think the other thing to think about there is really kind of proactive symptom management. So especially pain management and making sure that, patients and older adults are being assessed for pain, and accessing from that the appropriate treatment that they need. One of the things that's really important, certainly in long-term care facilities and kind of care homes, is avoiding unnecessary or inappropriate transitions. So that could be ensuring that unnecessary admissions to hospital don't happen, and trying to really respect the wishes of an older adult when it comes to the place of care or the place of death. That would be their preferred choice. So again, part of that is having conversations early and really establishing and respecting treatment choices and preferences. And I think another part of palliative care that sometimes we don't talk about is the support to families after death. So palliative care in many ways doesn't end at the death of the person, because families and caregivers often need more emotional support after death, or ongoing emotional support after death, in terms of kind of bereavement support. So that's a really important part of it too. So for me, good palliative care is delivered early on, but it takes into account the whole person and their families and the people involved in their care.
Thank you. And yeah, I like that acknowledgement that it's not just an individual, that we're all connected, and the importance of caring for families as well. I'm just going to go to the chat briefly, because we have a question that I think fits in quite nicely with this part of our conversation. So this is from Shmuel. So Shmuel is a regular contributor, and we are so grateful for his questions every week. So he's wanting to know what, according to you, ought to be the role of governments or maybe health authorities in developing effective end-of-life care for older persons. So more that policy level.
That's a big question.
Yeah.
I think I was going to come on to this later, because it's one of the areas which I think is a future direction. But I think for me, this is part of a much wider thing, is that we don't talk about death that much. And, with some of the ongoing debates going on, there's almost this kind of dichotomy, is it's becoming such a pressing issue with kind of an aging population, and more older adults dying, concerns of care homes with COVID. But at the same time, it can be quite a taboo subject. So I think part of the process of getting this into policy and at a national level is actually having these dialogues and having these conversations, and making it a bit easier for people to talk about palliative care and talk about end of life in general. So I think talking is the first thing. And the second thing is really recognizing palliative care. In the UK, we have the end of life care policy. And I think that, there's areas in that to develop, but definitely having these policies available and emphasizing, palliative care for older adults has different challenges. So there isn't a one size fits all approach, I think, to palliative care. It's, this varies a lot by different groups.
Thank you. And that transitions really nicely to my next question. So understanding, like you said, that palliative care can be needed and implemented across the life course, what are some challenges that are specific to older persons when it comes to providing palliative care?
Yeah. I think end of life care is a difficult subject for any age group. But certainly with older adults, in England, we have around 500,000 people die each year, and 2/3 of them of those who die are aged 75 years or older. And within that within that number, 1/3 of deaths are among people aged 90 years or older. So we kind of think that palliative care and end of life care in older adults would be something that's quite well developed and quite well talked about. But that actually isn't the case. And one of the reasons that I think isn't the case, and this is a point where I really wish I had a PowerPoint slide, is if we think about the kind of prognosis of different conditions. So I'll try and do it with my hands. But if you think with cancer, what you often see with cancer is a period of relatively short period of rapid decline. And that is in some cases or in a few cases, quite predictable. So we can see that trajectory from the point of diagnosis. And again, with heart and lung failure, you see this kind of long-term decline with periods of intermittent, serious episodes, and not really returning to that previous level of health. So again, from a diagnostic point of view, from the point of diagnosis, there's a clear kind of trajectory. But when we think about older adults, what often happens in older adults without a specific diagnosis of cancer or heart or lung failure is you see this what's called a prolonged dwindling, where over a number of years, there will be frailty, there may be dementia, and you might have a number of different conditions that are all interacting. So from that, deciding when somebody's approaching end of life can be really difficult. So I think that's one of the main difficulties. And I think the second difficulty that we see is obviously with dementia, with high levels of dementia, that has a lot of implications for capacity and proxy decision making and making choices at end of life, both being able to communicate preferences, but also being able to communicate when you're in pain and those things. So I think there's a lot of challenges that are inherent to older adults that sometimes we don't recognize, if that makes sense.
Okay, so to kind of confirm my understanding, it's almost like decline is naturalized, or like say compared to cancer where you see that rapid decline.
Yeah.
It's for when you're aging and end of life is approaching as a result of aging, it's so naturalized that maybe perhaps we don't introduce those conversations.
Yeah, and I think it's difficult because we see declines in older adults, and I see it in my own grandparents, and there's always, I often have this, is this the end? Is this approaching? And that was 5 years ago. So it can be a lot harder to see when end of life is starting, if you see what I mean. Yeah.
Thank you. Thank you. So would you be able to share some kind of thoughts or examples on good palliative care for older persons with us, like in regards to introducing those conversations early, or with someone providing care to someone with dementia, something like that?
Yeah. So I guess when we think about older adults, I think it's also really important that a lot of the aspects of palliative care that are important to younger adults are also important to older adults. But I think a lot of the important parts about providing palliative care to older adults are also really important for an older adult with dementia. So again, we're looking at things like, starting those conversations early. If there is a dementia diagnosis, starting those conversations about what preferences might be relatively early on. And also integrating, like I say, any palliative care with kind of ongoing treatment like medication. So it really has to be, based on the needs of the person. But in terms of dementia, what I'd probably say is, symptom management is really important because a person not being able to communicate, that adds so many additional difficulties, and there's a real risk there that somebody might be in pain or might be suffering and not getting that treatment because they're not able to communicate it. And we do have pain assessments that are appropriate for people with dementia, so it is really important that those assessments are done. I think the second thing with dementia is making sure, or with patients with dementia, is making sure that there's kind of a focus on shared decision making, and making sure that family members, caregivers are involved, and we're able to kind of revisit any decisions that have been made early on. Because what you often find with dementia, the aims very early on, if somebody has mild dementia, that might be more focused on kind of maintaining function or maintaining independence. And then as time goes on with advanced dementia, that might look more at kind of sustaining quality of life and maximizing comfort. So having these discussions about kind of advanced care planning, it isn't a static process. It's something that can be revisited as we go along. But I think the second thing that's really, maybe the third thing I've said now, that's really important with dementia is having kind of clear, consistent information on the likely progression and the status of a patient's dementia, and having that information shared to make informed decisions. Because one of the key one of the key areas I think for future direction is making sure that people are aware not only what palliative care is and what they should expect, but also having clear information on what to expect at end of life, not just care to to make those decisions. So I think having a clear understanding of what potential progression is going to be, and having that kind of consistent across a number of healthcare professionals across the team is really important.
Thank you. So when you're saying consistent across the team, could you maybe share with the audience like what that team might look like who might be participating in that healthcare team?
So, for example, in care homes, you would obviously have, from a UK perspective, you would have, healthcare assistants who might not be clinically trained. You would then have, if you're in a nursing home, nurses who will have maybe some general palliative care knowledge, but maybe not specialist. You might then have access to specialist palliative care teams coming in externally, and then you would have a physician as well, in addition to maybe other external healthcare professionals coming in, and family members as well. And I think, certainly with dementia, but, in many conditions with older adults, the expert is the carer and the expert is the patient. So it's really important that we're looking at care for older adults at end of life from a number of perspectives and incorporating everyone involved in the care, I think.
Perfect. Thank you very much. So a big theme that's kind of come up a few times today is this importance of engaging in this open dialogue about death and dying. So how can anyone who's listening in today or kind of exploring palliative care and just wanting to learn more, how can they engage in this dialogue with their peers and family members? So in my experience, I have a background working in long-term care, and when I was working, I saw that there like discussions with peers, so between older persons, had a distinct difference in terms of the acceptance of death and that end of life was approaching, but that sometimes there could be a desire to protect family members from that reality, or that those conversations were very different between family members and an older person compared to two older people. So do you have any thoughts on that, on how people can approach it, or potential, I guess, barriers that sometimes emerge when having conversations as a family?
So it's interesting because I think, there are plans out there that we can use that have a number of questions and have guides. And when you try and put them into practice, it can be really difficult, no matter how prepared you are. So I think, one of the first things I'd say, I think, is not having the assumption, and maybe this is more for healthcare professionals, but not having the assumption that because somebody's an older adult, that they have accepted that they are at end of life, or they have accepted death. Because I think there's something, there's maybe an expectation at times that, well, because you're in your 90s, surely you knew this was coming, and that you would be okay with that, and that's not always the case. So I think having that understanding and going into it is really important. But these conversations are really challenging. So I guess part of it is thinking about who the right person is. And, this can happen within families, it can happen within care homes. Sometimes the person who really wants to initiate the conversation may not be the right person to talk to. And what you often see in care homes is actually an older adult may not want to talk to their family members, but are happy to talk to the healthcare assistant about it. So really having a number of people who can engage in those conversations is really important. Picking the right time, picking the right location, but also I think thinking about, if you're either a partner or a child initiating this conversation, what are your concerns as well? Because sometimes when we have these conversations, that actually the concerns we might have as a carer might be completely different to the concerns the older adult you're speaking to might have. So I think that's part of it, and making sure that these conversations are ongoing, and it doesn't have to be a kind of one meeting. This has been set, we can never change it. One of the things about advanced care planning and talking about preferences at end of life is it can change, and that's okay. So I think that's the advice I'd give on that one.
Thank you very much. So I see in the chat, Jane Teasdale, you're sharing that you presented yesterday at the conference on palliative and end of life care in Toronto, I believe, or you were presenting on person-centered care at the end of life in Toronto. And you've shared so many fantastic resources. Would you like to unmute and perhaps share a little bit of a summary of what you've placed in the chat?
Whoops. Hi, good
There we go.
morning. Yeah, so yesterday, well, we commented on more of the, I guess, person-centered care at end of life. So our discussion was how Mosaic brings that within our model of care. And we did write an article prior to that. It's bringing meaning to end of life, and advanced care planning requires a much more bigger picture solution. Death and end of life are moments integral to our social connectedness, our well-being, our sense of self, personal inner growth and meaning. Today, we are increasingly being asked to bring death into our homes, our hearts, our relationships, and our wider communities. End of life impacts a person, their families, social networks, and communities. It is a humanistic big system issue worthy of embracing fully and completely. End of life is impacted by loneliness and social isolation, clinical distance, and a resource of constrained healthcare system. On the positive side, we have the humanity of others, our cumulative need for meaning and its expression, and the vast social capital that lies underutilized in our communities. So I did write, definitely UK is ahead. Canada falls 22nd. I think in Europe, they were dealing a lot with the caring and compassionate communities. And a while back, the caring compassionate movement was getting traction here in Toronto, Ontario. But I think when COVID hit, a lot of organizations didn't either have the energy or the funding to continue with that. So I think there's a lot of work within Canada that needs to be done, and we do look to Europe and UK for the work that is being done there. Definitely person-centered care falls into that. Again, listening to the person and what their needs are, and being more holistic. A doctor from Mackenzie Health Hospital in York Region, Toronto, York Region in Ontario, they were talking of a more palliative care end-of-life unit, which brings more of a holistic approach. So having people that are singing at bedside, having someone coming in doing Reiki, someone coming in doing massages. So we definitely need to be more person-centered. And for the doctors to really listen, and to the palliative care teams to really listen to the patient and, of course, the family. So I'll continue. I've got some other points to add into the chat, but I don't want to take over from Danni. Okay, thank you.
Perfect. Thank you very much, Jean, for sharing that. And
you're very welcome.
Yeah, really gorgeous excerpt from your article.
Yeah.
So for me, it sparked a few ideas, but I think first of all, and I'll kind of turn it over to you, Danni, and perhaps Jean, you can elaborate if Danni isn't as familiar. But could you just kind of maybe share a little bit more about what the caring and compassionate communities, is it a movement, or what that is?
Yes, it was a movement. It was to get, I guess, all levels, including government, private organizations, and not-for-profit. It was about connecting families to resources, and I guess also implementing volunteers to help families in the community, either for going for visits, or if there's some type of care that the volunteers could help with, or a listening ear. So this is what happens within the funding component. Is 2 years were spent with meetings, collaboration, bringing people together. Funding wore out. A wonderful, we were starting to do a lot of work on a system that those that were part of that caring, compassionate community would have access to all these resources that we built up. and involving the community in that as well. So, but then all that fell without the funding, right? And it's a large component and thing to work on, just one organization, and you need everybody to help with that. So yes, in the UK they've done, you know, quite a bit of work on that. Yeah.
Thank you, Jane.
Yeah.
Danny, do you have any other thoughts you'd like to add in?
No, I think Jane really made the point really well. And I think, you know, what was interesting for me coming into palliative care, and again, not being from a clinical background, to me, sometimes there's a bit of a focus on the hard skills. So, you know, knowledge on pain management, knowledge on medication, but there's also the softer skills, like, you know, having conversations, you know, engaging with volunteerism and wider network and joint working. So I think that was something that the compassionate communities really picked up on, is this much wider approach to palliative care and taking it beyond physical symptoms. And I think that's really important. Yeah.
Thank you. And I guess also beyond that professionalism of you know, like obviously there is training for those softer skills, like you said, but also it's so relationship dependent as well,
Exactly,
right?
yeah.
Yeah, that's really fascinating. Thank you both. So I also had a question, because Jane, when you were reading that excerpt from your manuscript, you were talking about social isolation, and kind of that role in that some people, or that, yeah, I guess consequence or phenomenon that some people experience towards the end of life. So Danny, obviously the COVID-19 pandemic resulted in lots of isolation for older persons. So how did, the pandemic impact approaches to palliative care, and are we still seeing the consequences of that today?
So I think my work mainly focused on end of life in care homes during that time. And I mean, you know, my current role is interviewing care home staff about their experiences. And at times it is really, really difficult hearing those experiences because, you know, certainly in the UK, because of visitation guidelines, it was difficult for families to visit at end of life. And it was often up to kind of care home managers to make those decisions. And as we've already seen, you know, understanding when end of life starts with an older adult can be really difficult. So suddenly you're trying to organise families coming in at a time during lockdown. And it was incredibly difficult. And I think the second thing that came out of it was the kind of the emotional burden it put on care home staff in terms of having to take on this role of caregivers, just so many people experiencing end of life without the kind of support from the community. So without having volunteers able to come in, without always having family members to come in. And I think that really illustrated, you know, the role of compassionate communities and the role of the wider people involved in care. So I think, yeah, I think it really made the case for that.
Yeah, and I know in Canada, even just at kind of the height of the pandemic, it was sometimes those, say, spiritual care practitioners or the non-physical care staff, it was also really hard for them to access their patients, which caused a huge amount of distress as well.
Definitely. Definitely.
So we have a question from Mitali Mystery. So Mitali, would you like to unmute and ask your question about integrating palliative care?
Yeah, for sure. So my question is kind of, how can we, in a really empathetic way, start to discuss the concept of palliative care kind of early on in life or throughout life even? I'm trying to, you know, kind of compare it to something else that we learn in life, but different stages. Maybe we don't learn the entire concept of it, you know, quite early on in life, but, you know, we kind of understand it. And so when it gets to that point where it happens unexpectedly to us, you know, we're semi-prepared or we have an idea of it going into it. So it kind of prepares us mentally or physically, you know, you're like, you know, this is a potential option in my future. How do we kind of go about doing that? Thanks.
So it's very interesting to think about, you know, how we talk about this, and my personal view is that we you know, we should be thinking about end of life before we need to. So actually having those conversations and even actually just on our own self, just thinking, actually, what does that mean to me? What are my preferences? But I wonder in some ways if that's too idealistic, and actually, you know, when suddenly you're faced with that situation, your whole, you know, perspective may change. So I think there's a bit of a role in general education, and I'm not entirely sure myself where this needs to come from about understanding end of life and really normalizing, you know, having an understanding of what happens at end of life, you know, what bereavement might happen, and an understanding of what the emotional, spiritual and physical needs at end of life may be. But where that should come from, I don't know. And I think, but it's a really interesting area in terms of, especially when we look at kind of national policies, how do we normalize this, and how do we talk about this more? And I think we even see it in, you know, the terms we use to describe end of life. Very rarely do we say somebody's dying. Often we say no longer with us, we're coming to a point. So I think even within that, there's, you know, sometimes a bit of a misconception. So we're really scared to talk about it. So I don't know if that's answered the question. It's a more question.
Yeah, for sure. It's a very hard question. So just to get your thoughts on it.
Well, I also think it's such an individual question. Like what works for me or what's important to me will be very different for what's important to you, Danny, right? Like you can't just have a one size fits all answer or solution. Thank you. So I know I have so many questions, but I will turn to the chat first. Eileen, would you like to unmute to ask your question about spiritual kind of components of care?
Thank you very much, Sarah. And Danny, thanks very much for agreeing to the topic and sharing your research with us. I'm in Ireland. Can I ask you about, you did in the definition of palliative care mention spiritual aspect. So has your research considered the spiritual aspect and the faith beliefs of the individual in relationship to both the end of life and palliative care? And in particular, we're going through legislation in respect of assisted dying, and I think the whole debate is also the same in the UK, and that's raising a whole pile of issues which I don't appear to have picked up in the conversation so far. Thank you.
Yeah. So I'll start with the faith-based question first. So I think in PACE, in the information we put together for the PACE study, which was looking at palliative care in care homes in Europe, one of the first steps of the PACE program was having a looking and thinking ahead document, it was called, and it talked about after admission having this conversation with the resident and their families and what kind of things were important to them, and faith and spiritualism and any kind of religious requests were included in that, and that is, I think it's a really important part of the conversation to have, and it will vary a lot in terms of, everyone has different views, in terms of, some people may be religious and follow a specific faith, but I think spiritualism extends to those who maybe don't have a specific religious faith, but also have spiritual views. And I do think there's a bit of a role for more education on the spiritual side of palliative care. Certainly when I was in Canada, I went to one care home that had a strong Jewish population, and seeing the lengths that the care home had gone to accommodate those beliefs in terms of preparing the body after death was completely new to me, because it was something I hadn't experienced in the UK. So having, palliative care professionals and the numerous settings having an awareness of different faiths and what that will involve, I think is really important. So I agree that it's a really important part of palliative care that sometimes could be done better. In terms of kind of the debates on assisted dying, you're completely right. We are going through those debates in the UK at the moment, and it is such a complex area. I mean, the two things that strike me when we talk about assisted dying and the debates on that is I think we need a really open dialogue on it. And I think we need that open dialogue both at a national level, because this is obviously something that people feel strongly about in different ways. So it's really important that at a national level, people have that option to talk about their views and what their preferences are and what should be available in different countries. But I think there's also something about being open to those discussions at an individual level. And I was in Japan recently where assisted dying isn't being discussed, it's not being debated at all. And one of the people I spoke to he's a gentleman in his 70s with heart failure, and he really wanted to talk to somebody about assisted dying. And he said to me, you know, when I tried to talk to my healthcare professionals, when I tried to talk to my family, nobody wanted to engage in this conversation. And in some ways, not being able to talk about his thoughts was actually more difficult and caused more damage than just being able to sit down and say, actually, you know what, sometimes I feel I'd be better off dead. And the person who he was able to talk to was a healthcare assistant who came in on a daily basis, and that really helped him. So I think there's something there about having those debates at a national level, but also being able to have them at an individual level. So again, I mean, the only other thing I'd say, and I'm conscious that I'm going over time, is, you know, when we talk about assisted dying, we really need to talk about it as well in how it would apply to everyone approaching end of life and what that would mean for older adults. You know, as we've just talked about, there's a lot of challenges there. So we need to make sure that whatever is coming into legality is appropriate for everyone, including older adults. So I hope that answers your question, but I'm aware it is a big area for debate.
Thank you very much.
Thank you, Danny. So I see in the chat, Francis Wilkinson, you're talking about volunteers and how many older people don't have any. Would you like to elaborate on your thoughts a little bit?
Sure. I just, can you hear me?
Yep, we can hear you great.
Yes, okay. Yes, I just noticed when Jane was talking about palliative care and her approach, that she mentioned volunteers, and certainly in Canada particularly, which is such a spread out country, there are so many older people who don't have family. I mean, we all talk about family as part of this, but very frequently that doesn't exist. And so we actually need some other people involved. And I wondered if Jane had anything she might want to add about the role that volunteers might play in this, because I see this as one of our biggest problems in Canada, is that many older people, you talked about social isolation, many older people are living alone, and when they come towards the end of life, they really don't have that support at all. So I just throw that out there.
Thank you so much, Francis. I'm not sure, Danny or Jane, if either of you would like to share your thoughts.
I can comment. I can comment on the Ontario, Canada. Yes, through the many hospices in Ontario. I'm just familiar with a lot of them around. They do spend a lot of time with volunteers. And again, you were mentioning, yeah, a lot of families, you know, individuals don't have families to help. So, you know, to provide that connectedness and a listening ear and to be empathic and compassionate, they really need somebody in the home just to have a conversation, hold their hand, do a little bit of, you know, light cleaning or doing some grocery shopping or running errands. So it really helps out. And I know after COVID, it's been sort of difficult in Ontario getting the volunteers back out. So agencies are really trying to spend time and recruit, but most definitely we're needing those volunteers. Yeah. Thank you.
Thanks, Jane. Thanks, Francis. Danny, do you have any other thoughts you'd like to add?
No, I completely agree. And I think, you know, one of the strengths of how we talk about palliative care now is that you're right, we do incorporate the families, but we don't think as much about, well, what about somebody who doesn't have that family, and how do we provide that support and make sure they get that support? So no, I completely agree.
Thank you. And that question, it kind of sparked this curiosity of mine. Do you find that there are certain populations of older persons who may not have as easy access to palliative care or end-of-life care? So whether this be older persons experiencing homelessness or certain socioeconomic groups or faith-based groups, do you see that there's a little bit of a difference in terms of who can access care?
I think, in terms of, my work in care homes, and I think this is true in some ways across the care board, in not just palliative care, but I think if you're an older adult and you have, either a partner or children, there's often a sense that you have somebody fighting your corner for access. So I think having access to carers or having access to wider family networks would, I don't want to say improve your chances, because palliative care should be available to everyone, but I think in terms of navigating the health system and making sure of access, I think that does help.
Perfect. Yeah, thank you very much. So we're slowly approaching, or quickly approaching, the end of today. But I was wondering, in your research, kind of going back to the COVID-19 research, what were kind of the main findings of that research, or what do you feel is really important that we learned from the pandemic, or based on our pandemic experiences?
So we're currently doing the analysis of the data at the moment. I mean, my hopes for something positive to come out of the COVID-19 pandemic was to raise awareness of care home residents and to raise awareness of older adults, and end of life, and to try and get things in place that, were there to be another pandemic tomorrow, we would be able to provide better care and not experience what we experienced the last time. And I think part of that in the UK is providing more training and support to healthcare assistants and to care homes. I'm a big fan of the massive open online courses, or the MOOCs, and I think what I really like about them is that they're free, they're online, they're accessible, but also they give a chance for students to really share their experience and to practice those kind of softer skills and actually be open about, actually, I found this really difficult when dealing with death. I find it difficult to initiate these conversations. So I think access to training for everyone, and I think that training, that can be for volunteers, that can be for family members. So having that awareness, I think, is one of the key lessons we can learn from that time.
Okay, and I'm kind of hearing in your sharing that a course can create the opportunity for engaging in conversations about, oh, I found this hard, and do you have any, what are your strategies? So there's an element of peer support as well. I'm not sure what kind of the specific focus of your population or of your research was within COVID-19 and the care homes in the UK, but did you ever see examples of peer support happening with either family members or with care workers themselves?
So I think, certainly in the UK, there was a lot of support between the staff members who remained. So we had a scheme where care staff could either work, or if they were vulnerable, they would be furloughed and wouldn't need to come into the home. So the ones that did remain in the home, often in the interviews, they talk about this real sense of belonging, of support, and kind of supporting each other during that time. So I think there's a lot of peer support in care homes, or in some care homes during COVID, where it worked really well. But I think what maybe has come from that is access to training on, for example, palliative care, and really developing that. Yeah.
Okay, so kind of furthering on that journey of providing further expertise. And I find it fascinating that you're identifying healthcare assistants. So in Canada, specifically Ontario, they're referred to as personal support workers.
Okay.
But so these tend to be the people with the least amount of training, and they tend to typically be paid the least amount for their work. So how do you think that training, because they interact, like you said, a lot more with the residents themselves, that they know the residents, they know how they like their tea, they know their family members typically quite well as well. So how do you think their experiences perhaps differ from, say, a physician in terms of the type of palliative care they provide to older persons?
So, and I think this is where the definition of palliative care and what we, think about in terms of not just pain management really comes in, because, in care homes, it's often the healthcare assistant that can be sat with a resident, holding their hands and talking to them. I think the other thing that comes out, certainly in some of the care home research that we do, is, care home assistants aren't able to sign, advanced care planning forms. What they are able to do is report that information up and be part of the team. So I think part of the training that we would need in care homes is understanding what everyone's role is. Okay. And how they are part of a wider team, like we say, with volunteers, with family members, and understanding, you know, if a resident has said, actually, I've been thinking about this today or that today, who that person can then go to you know, to enact those decisions or to take that conversation further. Or if, for example, you know, a healthcare assistant notices, actually, I think a resident's in pain, who they can then report that up to and how they can take that further. So I think, you know, everyone has a role in this, one way or another.
Yeah, certainly. And I think that idea of identifying the roles, first of all, makes sure that everyone feels listened to and heard, and there's that opportunity to contribute and be a valued member of the team. Thank you for that. So we're approaching the end, so I'm going to ask you to share a key takeaway message with us today. But before that, I'm going to introduce next week's key topic and speaker. So please join our discussion next week with Jennifer Jones and Larissa Moniz from Fighting Blindness Canada. We'll be discussing access to vision health, with the session being moderated by the wonderful Katrina Buzanis here from the IFA. But yes, Danny, would you be able to share some key takeaway messages to leave our audience with today?
So this is something that a colleague in Canada said to me, and it stuck with me. And she said, no one has ever died from talking about end of life. And I think that's really important that like I say, we are having these conversations. That's the first step for me.
Perfect. Thank you very much. And we'll be providing lots of resources in the session recording, which will be available on the IFA website. So I just really want to extend a huge thank you once again, Danny. I would also like to thank everyone for attending another great week of the Global Cafe, and also highlight the open-ended working group on aging is fast approaching. So we had Frances Zainadin and Ellen Graham from the Global Alliance on the Rights of Older People here a few weeks ago to join us to describe what the open-ended working group is and the legal gaps in the protection of human rights of older persons. And this was also focused on the right to healthcare and understanding palliative care as a key component of healthcare. So in 2 weeks' time, UN member states are meeting at the United Nations in New York to discuss these gaps and a response. So for the audience, if you have already not done so, please do sign the petition calling for a convention on the rights of older people. And a link has been placed in the chat by my colleague, Luana. So many thanks once again to all the incredible people at the IFA who have supported this in every Global Cafe, and in particular, Luana Calnego, who makes all of this happen behind the scenes. We'd be lost without you, Luana. So I hope to see you all next Friday and wishing everyone a great weekend. Thanks so much.